Hello everyone. So we'll be covering the topic of large airway diseases in pediatric patients, and it is a very important topic because the small airway diseases are normally usually covered, but large airway diseases are also a very important spectrum that we have to cover. So coming to the anatomy, the large airway covers the entire tracheobronchial tree up to the level of the segmental bronchi, starting from the trachea. And in pediatric patients, it is very important because we need fast acquisition times, we need high spatial resolution for anatomical coverage, and we need to reduce the need for sedation. And that is why the modalities that we choose for imaging the large airways compromises of the CT as well as the MRI. Out of that, CT is exactly the main workhorse of the large airway diseases. Among the cine CT, cine CT is actually we take contiguous acquisitions of the CT so that the diseases which are associated with the respiratory or the cardiac motion that are more appropriately demonstrated while the contiguous acquisition is going on. The drawback is that there is increased radiation dose. Along with it, 4D CT scanning can also be done. The 3D CT is the normal usual CT that we do. The fourth dimension is actually the time. So again, we use the respiratory and the cardiac motion, and we use a multiphasic acquisition. And so that we can answer the clinical questions regarding the tracheobronchomalacia. Just like osteomalacia, tracheobronchomalacia is when there is weakening of the cartilage which is forming the trachea and the bronchus. So that term is that is known as the tracheobronchomalacia. We can also study the complex vascular rings and slings while we do the 4D CT scan. Again, the cine MRI is similar to cine CT, and the contiguous acquisitions are done. But the advantage over CT is that because of the contiguous acquisition, CT gives a lot of radiation dose to the children, and that we can avoid by doing a cine MRI. But the problem with cine MRI is again, we need it has a longer acquisition time, so we have to actually sedate the patient, and otherwise it can provide us the similar information. We use the ultra short echo sequences while doing the CNA MRI so that the respiratory and the cardiac motion is do not hinder the acquisition. And again, the susceptibility artifacts that are a problem while we do the chest imaging, that are also reduced while we do the ultra short echo sequences. Now coming to the anatomy and the embryology of the tracheobronchial tree. The trachea extends from the lower portion of the larynx at the level of 6th to 7th vertebra, cervical vertebra, up to the level of carina, that is at the level of the T3 or the T4 vertebra. So this is at the level of C6, C7, and this is the carina is almost at the level of D4 vertebra. Then it bifurcates to form the main bronchi. In pediatric patients that we have talked earlier also, the larynx is shorter in size, and so this the starting point of trachea is almost at the level of C3, C4, and versus the C6 level where it was seen in the adults. The trachea is also short, as the neck is also relatively short in children. The length can approximately be up to 10 to 13 centimeter, and the diameters can be approximately 2 centimeter. Histologically, if you look at the cross section of the trachea, the anterior and the lateral margins are formed by the entire by the cartilages, while the posterior wall of the trachea is actually formed by only the smooth muscles and the epithelial layer that are located on the posterior side. And that is why the pathologies that are affecting the cartilage occur more on the anterior and the lateral side, whereas the posterior wall is actually vulnerable to the infections as well as the other processes which can involve the soft tissue. So as I told earlier also, the pathologies like tracheobronchomalacia and the osteopathica that is seen in the older age group, they are also comparatively seen more on the anterior side, whereas the posterior side is usually not rigid as compared to the anterolateral walls of the trachea, and it usually moves with the respiration. So during the inspiration and during the expiration, you can see that there is a difference in the configuration of the posterior wall. You can also identify if the particular CT scan has been taken into in inspiratory or expiratory phase based on the position of the posterior wall. So if the posterior wall is flattened, you know that a proper inspiratory effort has been taken by the patient, and because of the increase intrathoracic pressure, the wall becomes flat, whereas in the expiratory, because of the negative intrathoracic pressure, it turns forward. And that is where we know that the scan has been taken in the expiratory phase. Again, to discuss the embryology, the trachea actually develops from this is the foregut, developing foregut, and the tracheobronchial diverticulum actually arises from it. This is the respiratory diverticulum, and it will later continue to bud caudally to form the tracheobronchial tree. And you can see that during the 4th week, this is during the 4th week, the B and the C image, you can see how the bilateral lung buds are forming, and this is the process which is giving rise to the trachea. So again, it is important to know, because the congenital anomalies that are of the respiratory as well as other gastrointestinal tract in the region of thorax, they are associated with each other. And the congenital malformations as well as the cysts that are the bronchogenic or the foregut duplication cyst or the neuroenteric, they are all related to each other, and depending on the location, we can sometimes differentiate, but it is very difficult because they are mostly have a similar origin. It is just on the basis of the epithelium that we try to differentiate these. So covering the diseases of the large airway, we'll be dividing them into congenital as well as the acquired forms. In the congenital, again, we have divided them into static and dynamic forms. Among the static forms, we have the intrinsic as well as the extrinsic pathologies. Among the intrinsic, the diseases which are located within the tracheobronchial tree includes the tracheobronchial branching anomalies. Then again, we can have the pulmonary agenesis, aplasia or hypoplasia. We can have bronchial atracheias, and we can have congenital tracheal stenosis. Among the extrinsic pathologies, again, can have non-vascular or vascular pathologies. In the non-vascular pathologies, we have the foregut duplication cyst as well as the tracheobronchial fistulas, whereas in the vascular pathologies, we have the vascular rings as well as the pulmonary arterial rings that we'll be discussing in detail. Among the dynamic forms, we again have the tracheobronchomalacia. As I told you that during the expiratory or the inspiratory phase, there is a difference in the diameter of the trachea because of the weakened cartilages. So this is dynamic because sometimes it is appreciated only if you take the inspiratory and the expiratory forms, and the collapse is actually visible. So if you do the bronchoscopy of the patient also, you can sometimes under vision, you can see how the airway is collapsing under during the inspiration because of the negative intrathoracic pressure. Then among the acquired forms also, sometimes you can have tracheobronchomalacia or tracheobronchial fistulas. Then acquired tracheal stenosis, foreign body aspiration, neoplasm, and inflammatory pathologies are also some of the acquired pathologies that we will be covering. So among the congenital airway diseases, as I had already told you, they are mainly divided into two categories: the static anomalies as well as the dynamic anomalies. The static anomalies are static because they remain unchanged during the examination, whereas the dynamic anomalies, they are distinguished by their contiguous change and require special examination protocol to better visualize them. And we'll start with the static anomalies. Among the static anomalies, we'll first discuss the intrinsic lesions. Coming to the tracheobronchial branching anomalies, they are mostly seen in 12% of the adults that are doing bronchoscopy. The two most common causes of congenital anomalies are the ectopic as well as the supernumerary bronchi. So ectopic, as we understand, is the ectopic location of the particular bronchus, whereas the supernumerary is in addition to the normal number of bronchus, we have an additional bronchus. So you should understand that in the ectopic bronchus, there might be non-visualization or absence of the normally located bronchi. So again, ectopic bronchi are more common than the supernumerary ones. And among the ectopic, also the tracheal bronchus is the most common one, in which the bronchus actually arises from the outer tracheal or main bronchial wall and is usually directed towards the upper lobes.